Hello and welcome everyone. Today we'll be discussing the management of encephalopathy that we see in advanced liver diseases. So the prevalence is 10% of the patients are affected at the diagnosis of cirrhosis. 20% of the patients with encephalopathy are diagnosed when it is decompensated, and up to 50% prevalence in patients with TIPS. The recurrence. Patients with first episode of HE have 40% risk of recurrence every year. Hospital readmissions. HE is leading cause of readmission in cirrhotic patients with advanced liver disease. The prevalence of HE has increased in recent years, leading to higher hospital care costs. Now, the impact and prognosis. It is associated with increased morbidity and mortality within 1 year. A patient with HE has higher risk of falls, fractures, road track accidents, and in quality of life, it significantly diminishes the quality of life both of the patient as well as of the relatives and caregivers. So, what is the definition? When do we say it is HE? The general definition, it is defined as a brain dysfunction in patient with liver failure or portosystemic shunt. It presents with cognitive alterations, personal changes, and mental disorders. The course. HE often has a fluctuating course, potentially not reaching levels detectable by clinical symptoms. Now, if HE is suspected without obvious symptoms, minimal hepatic encephalopathy should be considered. Specific diagnostic tests are necessary to confirm or rule out minimal hepatic encephalopathy. So types of HE. It can be episodic, which is suspected when clinical manifestation appear above a detection threshold, or persistent when it is diagnosed with clinical manifestation consistently above a detection threshold. Now, impact of the liver disease etiology. The definition doesn't account for the effects of underlying liver disease or the brain dysfunction. Factors such as alcohol abuse, viral hepatitis, non-alcoholic fatty liver, primary biliary cirrhosis can influence the HE manifestations. Uncertainty remains about the difference in the neurological dysfunction caused by the liver disease or comorbidity like aging or diabetes, which as such have neurological manifestations. It can be challenging to attribute the neurological disturbance to any one of these particular factors and specifically say this is the reason why the patient has a encephalopathy. So the classification, it is classified as patient with acute liver disease, patient with portosystemic shunt without chronic liver disease, patient with chronic liver disease with or without portosystemic shunt. The severity of the clinical manifestation. What we follow is the West Haven's criteria, which is staged at 1 to 4. Overt HE at least a temporal disorientation or asterexis. Covert HE, which is at the grade 1 symptoms with heterogeneous with different prognostication implications. The next is issues with inter-observable variability, particularly in milder stages, make the West Haven criteria weak, especially when you are using this criteria for clinical trials. Other classifications like hepatic encephalopathy scoring algorithm, hepatic encephalopathy grading instrument are more accurate and validated. So the time course, the episodic and recurrent. Recurrent episodic can be isolated events. Recurrent is when the bouts occur within 6 months or less. Persistent when some degree of manifestation is almost consistently always present. Now, precipitating factors. These are important precipitating factors bout of HE in presence of an identifiable precipitating factor. So, spontaneous is when you cannot find a precipitating factor. Acute and chronic liver disease, ACLF is a syndrome characterized by decompensation of chronic liver disease, organ failure, and poor short-term prognosis. It is marked by very significant systemic inflammation. Patients with both HE and ACLF have worse prognosis compared to those without ACLF. Reclassification of HE with type C and considering the presence of ACLF is under discussion. So this is the overall types. We divided into type A, B, and C. It can be covert or overt. Covert is mainly type 1, or when you do some tests and you find there is some abnormalities. Like degree 1 of the West Haven is personality changes, altered sleep pattern, and attention, which again is a very subjective finding, difficult to do it in clinical trial setup or even at the bedside. Here it is most of the time spontaneous, rarely with a precipitating factor. But B and C are something which is more associated with the precipitating factor. It can be recurrent or persistent, and it is usually overt. Here you have a disorientation which you do see in the patients. They have lethargy, apathy, asterixis, and finally if it progresses it can lead to frank stupor, gross disorientation, and even coma. So in this presentation what we are going to deal with is the 3 and 4, how to treat this group of patient when they present to the ICU. So coming first to the pathophysiology. In the pathophysiology, HE is not a single clinical entity. Neurological impairment of the liver dysfunction is complex and not completely understood. Liver failure increases the brain's exposure to substances normally metabolized by the liver. That is the basic understanding. So there are some key factors which will contribute to this encephalopathy. The most important of these chemicals is ammonia by far. So it is produced in the digestive tract by protein degradation of the by intestinal flora and the deamination of the glutamine. So increased systemic ammonia due to loss of hepatocyte mass and portosystemic shunts results in ammonia reaching to the brain. This has clearly toxic effects by being metabolized to glutamine in the astrocyte, contributing to the HE's neurological manifestation. Inflammation is a very important factor. Inflammation is linked with hepatic encephalopathy in fulminant hepatic failure as well as in cirrhosis. So in that context, it is something which you will find more common with acute and chronic liver failure. So inflammatory mediators, oxidative stress can disrupt the blood-brain barrier, causing neuroinflammation. Inflammation exacerbates the effects of hyperammonemia, and you also have manganese deposition. So impaired biliary manganese excretion leads to deposition in the basal ganglia, contributing to the psychomotor impairment. You also have hyponatremia, which is common in liver failure. Serum sodium correlates with the neurological manifestations. Finally, you have bile acids, which is elevated in plasma in advanced liver failure, and it has also linked to neuroinflammation. So neuropathological alteration, the ammonia-induced astrocyte swelling. Ammonia detoxification in the astrocyte causes osmotic stress, leads to the cellular dysfunction and neurological disturbance, involves impaired glutamate uptake and increased neurosteroid synthesis. You also have transmission alterations where there is increased GABAergic tone and NMDA receptor stimulation. You also have brain edema. This is because of the inflammation and the cellular hydration state due to increased intracellular glutamate concentration. And there is also impaired metabolic pathways and increased intracellular lactate, suggesting there is also an energy impairment. So there are some other contributing factors like the altered intestinal microbiota can influence the brain function and the clinical course over here. Circulatory derangement, nutritional deficit, sarcopenia, and other organ failures also have an effect on the neurological manifestation. Comorbidities like alcohol abuse and non-alcoholic fatty liver disease can also complicate HE. Muscle malnutrition is common, increasing HE risk and impacting the survival. So finally, coming to the clinical manifestations. So in the clinical manifestations, you can have mild symptoms, that is alteration in the attention, working memory impairment, psychomotor speed, and visuospatial ability impairment. So there are also progressive symptoms. These are personality changes like apathy, irritability, disinhibition, alteration in the consciousness and the motor function, disturbance in the sleep-wake cycle, which includes excessive daytime sleepiness. Severe symptoms would be progressive disorientation, inappropriate behavior and agitation, stupor, and coma. So rare symptoms are transient focal neurological deficits or seizures. So the main problem starts is when the patient starts to have impaired behavior and aggression. So many of the times these patients are sedated and given other type of sedative medications. So this results in a stuporous condition. So there is a confounding factor whether the stuporous condition is because of the drug that was given or is it because of the disease that has progressed. So that creates a doubt in the minds of the relatives as well as of the doctors. So how to diagnose? The diagnostic criteria is presence of the symptoms, that is evaluated by clinical scales to grade the severity of the overt HE, predisposing liver disease condition which must be present, and the exclusion of other factors. This is very important. You must also exclude conditions like uncontrolled diabetes, alcohol abuse, drug abuse, electrolyte impairments, severe infections, psychiatric disorders, epilepsy, dementia, apnea, IC bleeds, and stroke, which are again very commonly associated with a CLD patient. And the diagnostics tool for minimal HE is neuropsychiatric tests, like we have already discussed some of the tests. And for neurophysiological, like EEG can also be used. Pathophysiologically, lung function test is important. The Child-Pugh score, the MELD score, oral glutamine tolerance test, this can all be done. Portosystemic shunt assessment, this can be done with the abdominal CT scans. Cerebral structure test, like by MRI and spectrometry. And plasma ammonia levels are very common, and this should be done in all cases, but limited diagnostic utility, though it has a high negative predictive value. So it means that basically that if the ammonia is normal, unlikely the cause of the encephalopathy is liver disorder. So these are some of the common precipitating factors. This you must know. The common factors for episodic encephalopathy are infections, GI bleeds, diuretic usage, electrolyte imbalance, constipation, and unidentified causes. For recurrent episodes, that is episodes that occur very frequently and multiple admissions within 6 months, that is electrolyte imbalance, infections, unidentified constipation, diuretic overdose, and GI bleed. So this is basically the priority at which you must think is the most likely cause. So how to treat? What do we do to treat this? The general target is to minimize the duration, intensity, and the consequence of these episodes, prevent recurrence, limit the impact of the life of the patient and the caregiver, implement measures to manage the airway, stabilize the hemodynamics, prevent self-injury, and maintain adequate nutrition. Actively search for and treat the precipitating factor. As we have seen over here, the most common causes being electrolyte imbalances and infections. Now, implement specific measures to intervene on modified pathophysiological mechanisms. So ammonia reduction strategy is most important. You give non-absorbable disaccharides which reduce the ammonia production and absorption by favoring intestinal transit and lowering the fecal pH. Effective in clinical manifestation of HE prevention as well as on reducing mortality. It is a treatment of choice for acute HE and preventing recurrences. Rifaximin, it is a most commonly used antibiotic and is effective in the secondary prevention, works in microbiota functionality, preventing the recurrent episodes of HE. Combination with lactulose, more effective than lactulose alone in treating episodic overt HE and reducing the mortality. Probiotics promote recovery and delay the development of overt HE, improve the quality of life, and reduce the plasma ammonia levels. Branch chain amino acids help in eliminating the ammonia and could improve HE symptoms, but then the evidence is not very strong over here. And Lola, there is a meta-analysis which shows some kind of improvement, but then as we have already discussed, the quality of evidence is extremely low for these treatment modalities. So management of recurrent or persistent, you need to go for some kind of a portosystemic shunt occlusion. It is beneficial for selected patients who have a well-preserved liver function, that is MELD less than 11. Consideration of a liver transplant is done in most of the cases. Post-TIPS HE management, in those cases you have to use non-absorbable disaccharides, antibiotics which may be insufficient. Alternative therapies like fecal transplantation can be done. Nutritional approach is important. Use branch chain amino acids. TIPS modification through shunt diameter reduction may be an option for refractory post-TIPS HE. Controlled expansion stent may be preferred to reduce the post-TIPS HE. Now the treatment targeting inflammation can be used, like rifaximin, probiotics. This can reduce the inflammatory pathway. Albumin, which can be used as an anti-inflammatory antioxidant and has shown to improve survival of HE, though we need further studies over here. Liver transplant, extremely important. Overt HE is an indication for liver transplant in patients with advanced liver disease, and patients with severely overt refractory to maximal therapy should be referred to a liver transplant center immediately for transplantation. Future horizons, we see some new treatment options like fecal transplantations, ornithine phenyl acetate, which demonstrate efficacy in reducing ammonia and improving the cognitive function. Encouraging preliminary results have been seen, but we need further trials over here. So to summarize, this is how you should manage the patient's symptoms. You must first see whether the symptoms are suggestive or compatible with HE. these are the things which you should find, that there is some kind of a liver failure, there is some kind of a severity with chronicity of this condition, and probable portosystemic shunt. If you find all these things, but you must rule out the factors which you have already discussed, like hypoglycemia, hypothyroid, drugs, ethanol toxicity, Wernicke's encephalopathy, and various other things, which again are very closely linked with CLD. So rule out these causes, and you have these manifestations, you have ruled out these things, so you can safely say the patient is in hepatic encephalopathy. So there are some generalized measures which can be done in all patients, like ABC, preventing the harms and other nutritional factors, and specific drugs that can be given, like the lactulose, antibiotics like rifaximin, branched amino acid prebiotics, embolizations, and transplants. Thank you for your patience.